Thank you for joining the Heilbrunn Department of Population and Family Health's Fall 2020 seminar series. Today's seminar is with Dr. Kelli Stidham Hall on Rising to the Challenge, Building an Interdisciplinary Research Center to Improve Reproductive Health Outcomes and Reduce Disparities in the Southeast.
Okay, hi everybody. I'm always really happy to see people in this weird environment that we're living in. We're very excited for our last seminar of the semester, and I'm very, very happy to welcome Dr. Hall, who's an associate professor in the Heilbrunn Department of Population and Family Health, and an adjunct associate professor with tenure at Emory University's Rollins School of Public Health. Kelli completed her PhD from Columbia, a postdoc at Princeton, and an NIH K-12 at University of Michigan. She's the founding director and principal investigator of the Center for Reproductive Health Research in the Southeast, as many of us know it as RISE. Dr. Hall's NIH and foundation-funded program uses biosocial and multi-level frameworks and its interdisciplinary methods to study the social determinants of reproductive health and health disparities in the US and Africa. She looks at policies and other macrosocial factors on family planning service delivery, access to care and outcomes. Her greater than 15 years of clinical experience as a primary care advanced practice nurse informed her other theme focused on understanding and addressing interrelationships between reproductive, mental, and behavioral health and social well-being during adolescence and young adulthood. She has many, many other affiliations. I will simply say that we are completely thrilled to have her join our faculty, and she has joined us with a bang. So we are very happy to hear from her today. Welcome, Kelli. Thank you for doing this.
Thank you so much for having me, Chair McGovern. It's an honor to be here with you all. Like I said, last but not least for the semester seminars for the department. I have been thrilled to join the department even despite COVID, and I've received a warm welcome. So I'm really excited to get to know everybody and the students and share a little bit about my work from Emory today. And I want to thank Lizzie too for helping me with all things logistic and advancing my slides for me. And I think she'll also be fielding questions. So Lizzie, I think we can pull up the slides. Thank you. Yeah. So like Terry said, I'm excited to share a little bit about our experience building a research center focused on reproductive health, health policy, service delivery, and access to care in the Southeast region. And next slide, please. I would like to acknowledge my amazing team. Most of them I still am working with and had the great honor of building this great collaboration. I think now we have over 75 faculty, students, trainees at all levels, and staff working with RISE. And so it's been a real honor to get to work with everyone on this important agenda. Next slide, please. And okay, that's our lovely staff. Next slide. And so I'm actually really excited to share. It was very hard, I will say, to leave the center that we built together. Of course, I was delighted to come to New York and back to Columbia and PopFam. But in any case, I had the pleasure of working to transition RISE and RISE's leadership to one of my most amazing junior faculty scholars, Dr. Whitney Rice, who's now the acting director of RISE. And I still get to work closely with Whitney and mentor her. And then our co-directors of administration. So this is what the future structure of RISE leadership looks like. And they're really thinking a lot about how to dismantle hierarchies and bring diversity to the leadership team. So it's been a real treat watching that evolve. Next slide. So here's just a brief outline for today. I just wanted to quickly go over the public health significance for this body of work. Most of you, I sort of don't want to preach to the choir, but most of you know about the issues related to the need for contraception and abortion access. But I'll quickly highlight why the Southeast and why we focused in that region. present an overview of the center and what it was like to build the center, describe our initial research projects and the way that we go about research in terms of methodology and design, and then share a little bit about RISE's education core and RISE's translation core. So those are two complementary cores that we intentionally and proactively built to support the body of research. So next slide. So as many of you know, unintended pregnancy rates continue to be a challenge in the US as compared to other domestic and global developed countries. But women in the Southeast in particular experience high rates of adverse reproductive health outcomes. So unintended pregnancy rates are higher in Georgia and the surrounding states than compared to the rest of the US in terms of averages. Next slide. And so also similarly, the Southeast faces higher rates of maternal and infant mortality. And in fact, Georgia has been ranked among the highest, and it was the highest in 2016, in fact, with a rate of 39 per 100,000 women. So these are longstanding adverse outcomes faced by women in the Southeast and disproportionately by racial ethnic minority, in particular Black women and low-income women in the region. Next slide. Similarly, young women disproportionately have high rates of unintended pregnancy and unwanted births, again with the Southeast being higher than the national average. Next slide, please. And so one of the factors that contributes to these adverse outcomes is lack of access to reproductive health care. So we see that geography as well as structural issues in the region, including lack of providers, really shape outcomes for women and their families. And so here we see a map that shows the percentage of women living in a county without an abortion provider. So the darker shades mean higher proportions of the county without access to care. And you can see the South is faring pretty bad. And in Georgia, some recent statistics, 28, only had 28 abortion providers between the period of 2008 to 2011. And actually this has gone down even since that time. And they've seen a decline, so 13% just in those years. So again, not only are women faced with rural, sort of urban disparities in access to care, but also just a shortage at the structural sort of and health systems level. Next slide, please. So here is a map depicting how policies actually shape access to care and service delivery. So I know we've heard a lot about this within our own PopFam department, and we've been very focused on it in the South as well. There's just been a real onslaught of legislation designed to restrict reproductive health access, and in particular access to abortion. And so you can see the map here with the red states that are highlighted. So these are states that enacted some type of restrictive policy in 2016. And again, these numbers in terms of numbers of policies passed have dramatically increased. And so in the South, all states except Virginia have been labeled hostile or extremely hostile toward abortion access by NARA and the Guttmacher Institute. Next slide, please. So all of this was impetus for us to think, how can we begin to build capacity for research to study what's happening in the Southeast, sort of in our own backyard. A lot of the work that had been done previously was led by people in Columbia, which is where I was sort of born and raised, as well as San Francisco. And those were sort of known in part because of strong family planning communities and strong family planning provider communities and training programs. At those institutions, there had not been as much work sort of developed in the Southeast, and in particular in partnership with community organizations in the Southeast. So we really saw this opportunity to think about what we could do in Georgia and to sort of envision what it might look like to build a research and education and translation center to address these gaps. Next slide, please. So I get this question a lot. How did RISE sort of happen, and what did that look like in terms of process? And so I was so excited shortly after I got to Emory, actually, to be invited among a small group of scholars all across the country to think about proposing a concept, so a concept note, to build a program somewhat modeled after TextPep. Many of you probably know that the UT Austin policy evaluation program for family planning. It had been sort of a pioneer in some ways in leading policy relevant family planning research, at least in the family planning community domestically. And so started to think, okay, what other areas of the country might benefit from such a program? And so I quickly put together a concept note and sort of started to envision what a research center housed in the Southeast might look like, and really trying to leverage existing resources and collaborations and relationships. And so proposed a concept note, which was funded as a small planning grant. So we were on a one-year planning grant. And that gave us time to really build a vision and really think about our research strategy and a research portfolio, a group of projects that would address timely issues that Georgia and the surrounding states were facing. And so we put together, I quickly put together this team and thought about what a large grant would look like. And so we wrote the large grant, and it was successful. And so we were thrilled to launch the center in October 2017. So in the big scheme of things, we had the luxury of having time. Often you have to get the grant before, so the planning grant's quite luxurious from that perspective. But it did give us time to think really carefully about a vision for the program. Next slide, please. And I just really wanted to acknowledge going to Emory was a little bit like coming to Columbia in terms of the infrastructure that already existed in terms of maternal child health issues and gender issues. Not quite as strong as at Columbia, but there were definitely some complementary dimensions of existing efforts that I was able to leverage and think about garnering. I think in a lot of institutions, in my experience, efforts are often siloed, and I think that's what I love about the Global Health Justice and Governance Program is it's really intending to bring folks together in true interdisciplinary fashion, and that's sort of what we tried to do with RISE as well at Emory. And so these are some of the organizations that we quickly started collaborating with to build the research center. Next slide. And so, thus, there was RISE was born, and I tell this, RISE was born at the same time I gave birth to my son, Dylan. So there was a lot of exciting things happening that year. Luckily, we had great support to start sort of launch the work. And so our center's mission is to produce rigorous reproductive health and family planning research in order to improve services and policies and programs. And so we intentionally designed it with three cores. The first is a research core, and its objective is to advance the science on understanding and intervening on the multi-level determinants of reproductive health. So very interested in that multi-level frame and thinking about equitable access to care for women and their families and people, as well as service delivery and the way in which policies shape those things. Our education core was designed to prepare the future generation of interdisciplinary reproductive health and family planning scientists who were willing to stay in the region and build capacity. And then finally, the translation core, which was designed to facilitate translation of scientific evidence in order to inform dialogue, catalyze engagement, and facilitate policy action in the Southeast and beyond. So we're really interested in not just research for research's sake, but research that's intentionally community driven, and that's also, at the end of the day, going to help make social and policy impact. Next slide. So here is a list of our very initial set of research studies that were embedded in the research core. And actually these continued to grow over my time at Emory, and now there's many more. I don't have time to talk about all of them today. Maybe there'll be time for questions, but I did want to highlight sort of what they look like in terms of the portfolio. And you can see they're sort of all focused on some issue of social determinants of health and sort of at different levels of that social ecology. So the first project was the changing landscape of publicly funded reproductive health care in Georgia. And that project was focused on Title X. Back in 2014, the Department of Public Health had been a longstanding grantee of Title X at the state level in Georgia. And there was a sudden shift and a new grantee was awarded that was a consortium of federally qualified health centers. And so this really was remarkable in that it represented an integrated care model, quite different than any other state had seen. So we were very interested in evaluating what the implementation of that looked like in the FQHCs, and then what the de-implementation looked like in the departments of public health, and how that impacted access and sort of service delivery. So very implementation science focused. The next project is evaluating the impact of gestational age policies on reproductive health care systems in the Southeast. And hopefully I'll have time today to talk a little bit more in depth about this project, but essentially this was an evaluation of Georgia's 22-week abortion ban. So I'll share more in just a bit. We had a project focused on evaluating Georgia pregnancy resource centers, services and qualities. And this was, the state began giving money to PRCs, pregnancy resource centers, from a policy move some time ago, I believe in 2015. And so, there was a lot of controversy about what was actually happening in those centers and whether it was quality evidence-based care. And so we designed a multi-phase study to look at what women and people were experiencing in Georgia as a result of that policy. Another project looked at confidentiality and parental involvement processes for minors seeking reproductive health services, not just in Georgia, but in Alabama and Mississippi. We've been doing some work in those states as well in regards to adolescents' access to care. And the impetus for this was conversations around the judicial bypass process and what were legal stakeholders experiencing and how were they interacting in ways that were supporting patients trying to get through the system and the process and interacting with clinics. And so this was a really fun project too. And then finally, the last large project that we initiated was more of a community engaged intervention project, examining Georgia's faith-based communities. So this was a multi-level community organizing approach to reduce abortion stigma. And that study is still underway, but we ended up focusing on faith-based communities. And actually, Dr. Whitney Rice, whom I just introduced a second ago, is now leading that project. Next slide, please. I won't go through all of these, but because we started out with a pretty well-rounded set of projects, a lot of additional projects sort of spawned from the original ones, and with those brought really strong collaborations with our community partners. So one of my favorites is a Society for Family Planning funded collaboration with Sister Love. So Dazan Dixon Diallo and I had the opportunity to mentor some junior faculty and trainees on leading this community-driven project. So that's been a real successful experience. There were several others, including interacting with legislators and legislative testimony as data for Georgia's HB 481, which is the heartbeat bill or the 6-week abortion ban. And then there's several others that are engaging different types of stakeholders. Next slide. I'm going to quickly go through these slides, but I just wanted to give you a sense for the way that we sort of conceptualize the center's research portfolio. I care a lot about interdisciplinarity, and that's one reason why I love PopFam is because we are such an interdisciplinary department, and so was my training. And so we intentionally designed RISE to engage all different types of perspectives and methodologies from different disciplines. And so we really saw it as cross-campus and cross-cutting. Next slide, please. And we really took a multi-level policy evaluation framework. And so, we conceptualize policies as sort of distal social determinants of health, but really also caring not just on the outcomes, but the implementation of these policies and how that did affect systems. And ultimately the goal was, how can we identify more effective and comprehensive and positive reproductive health policies? So what can we learn from sort of the good and the bad, and really documenting barriers and facilitators to access. And we tried to take to heart the notion that to a decision maker or a policy maker, more than research is evidence. So social norms and beliefs and decision uncertainty and all of these things. And so tried to keep that in our minds to keep us grounded. Next slide. And another sort of major goal of the research core was to advance rigorous and innovative methods. And so here are some examples of the study design techniques that we employed across the research projects. And all of these represent some kind of element to estimate or determine, or better approximate, I should say, causal inference and magnitude of effect. And so these are all really fun designs, and you can see they're sort of reflective of the interdisciplinary approach that we took in terms of econometrics and psychology and social sciences combined with sort of clinical science. So it's really fun. These to epidemiologists, this is a really fun slide. Okay, next slide. And I did want to say, because I owe so much to our administrative team and my administrative director, we started out so big, for better or worse. Our research center really was launched as quite comprehensive, and I think that brought a lot of strengths, but it also brought a lot of administrative work. And so we really thought about this proactively too in terms of designing an administrative core. We really saw all of the components as very interrelated, and we thought that we needed to have a structure and a common process for research, but not just for the methods, as well as the data collection, the opportunities to share data across the cores, but also across the studies. And so this was very much a work in progress, and it still is, in fact. But we really tried to engage our participants and our stakeholders in developing that process. And in part, the administrative core really helped think about the center's evaluation plan, which we were just sort of finishing up when I left, as well as our advisory boards, sort of managing our advisory boards. Next slide. And here is a depiction of our education core. So we're really committed to training reproductive health scientists, sort of the pipeline approach. And so we even thought about engaging students sort of at all levels and even at the high school level to think about, again, who is likely to stay and build capacity in the Southeast. Next slide. And so here are some examples of our first cohort of students and fellows and trainees, and actually that grew and grew and grew. And so I've had the pleasure of working with many, but the good thing about having such a big team is that there are lots of faculty to help support and mentor the students and trainees so that they got a diverse set of experiences during that. Usually it was about 2 years that they were with us. But we developed and hosted a range of opportunities to engage students. Formal and informal mentorship programs, including engaging them directly hands-on in the research projects. And now many of them are actually leading papers and presentations, which is super fun. Theses projects and practicums, as well as student GRA opportunities. And we had a series of events, so in the spotlight, and we would choose, and the students would actually lead choosing timely issues that were faced by especially community partners, and so engage quite a diverse audience in bringing speakers in to present, lunch and learns and journal clubs. So there was a lot of activity in the education core, and my partner in crime, Jessica Sales, was one of the faculty members who was co-directing the education core with me. Next slide. And here's a depiction of our translation core. So this is the third core that I was telling you about. And it's really based on this idea that research engagement with communities and driven by communities is this iterative process. And so this is our sort of iterative model. And that we really believe that community should be engaged, and stakeholders, not just community, but policy stakeholders, clinic stakeholders, in every phase of the process. And the translation core was also a very busy core. And so I have to give kudos to Carrie Swiak and Katie Singh, who were helping lead the translation core. But we built a community advisory board, which was really critical. And honestly, I think I may have said this in my job talk, but one of the things that I would lose sleep over, this was one of the hardest things. And to be someone who'd always been in relationships with research, being in Atlanta, in the homeland of RJ, and really being challenged by our partners to think about how we can do a better job as academic researchers was such a transformational experience, and I'm still learning from that process. But we had a series of meetings with stakeholders. We did a translation core research project where we actually interviewed stakeholders to try to understand how our priorities could be shaped by the needs of our partners on the ground. There's numerous, we wrote policy briefs. We were engaged in HB 41 legislative testimony as expert testimony for the 6-week abortion ban. So the translation corps was very busy. And in fact, it turned out to be probably, well, Terry probably knows, multiple other jobs beyond what one person could do. So the translation corps is very much a focus of this next generation of RISE, and Whitney and the team are really trying to figure out how to make it even more of a core and sort of transcend everything that the center is doing versus any sort of siloed effort. So next slide. Here are our initial amazing community partners, many of them whom PopFam also has relationships with, and Terry and others in the department. These are incredible organizations who are really leading efforts in Georgia and across the US, in fact. So I look forward to continuing relationships with them. And in fact, some of them have already been presenters in PopFam classes this year or seminars. So it's really important work. Okay, next slide. So I wanted to just spend a few minutes talking about one of our projects that I thought you all might be interested in. This is the one that I was mentioning is focused on the 22-week ban. So evaluating the impact of gestational age policies on reproductive healthcare systems. And I have to say, initially it started out literally with the title of 22-week ban, and doing this work in Georgia and engaging different types of stakeholders to try to understand how that policy was impacting like perinatal health systems. We had to change the title, in fact, from a public facing standpoint. And so I learned a lot training in New York and then going to do the work in the South, which is where I was born, reminded me that sometimes you have to, framing really matters at least to get your foot in the door. So thus the long, clunky title. Okay, next slide. So Georgia's House Bill 954, it was passed in Georgia in 2012, and it limited abortions after 20 weeks post-fertilization. So this was 22 weeks post-last menstrual period. And this, so there was a lot of sort of murky details in the language of the bill, which lent itself to a lot of clinical confusion on how to actually implement it on behalf of providers and systems. But essentially, it required resuscitation of an infant capable of sustained life. The bill also specified that allowable abortions post 20 weeks must be performed in a manner that would maximize the potential for neonatal survival. There was a lot of really confusing comments around severe fetal anomalies and medical interventions that would increase neonate survival. And so not only did it have implications for family planning provision, but also for neonatology, for maternal fetal medicine, and for obstetric providers in hospital systems. So you can see here, this is a timeline of the bill, and you can see that a judge had issued an injunction while the courts were determining the legality of the restriction, but the law went partially into effect in January 2013. The injunction was lifted after I arrived at Emory, and the full law was passed in October 2015. So you can see the timeline. There have been challenges to the law since then, and then dismissal of the challenges. But this is significant because Georgia, and particularly Atlanta, has been a hub of abortion access for the whole southeastern region, right? And so by limiting late-term abortion access in Atlanta, this was hypothesized to have some devastating effects. There was an early study by my colleague Sarah Roberts and some of our Emory team that looked at what happened when the injunction was first passed, and so we saw that there were declining trends in abortion rates, in fact. So our job is really to think about the whole sort of process of the law getting passed and what happened over time after that injunction period. So that was the sort of mission of the study. Next slide. And so we had designed a comprehensive sort of mixed methods, multi-level study with the goal to evaluate the impact of the 20-week ban on health service delivery in particular. So we were sort of taking a systems perspective. We considered looking at the outcomes for women or for persons who were pregnant and seeking abortion, but that became very challenging to try to recruit patients into the study. So we ended up focusing just on systems. And not just for abortion provision, but again, also obstetric care. And so we wanted to look at describing the changes in the systems and service delivery indicators, and also investigating healthcare providers' knowledge, attitudes, and experiences related to the ban. So we used qualitative interviews and semi-structured in-depth interviews with clinic stakeholders. So these were not just providers, but also administrators, staff, sort of a whole diverse perspective. And then quantitatively, we examined induced termination of pregnancy data, which is reportable data for every abortion performed in the state to the Department of Public Health, so quantitative data. We also developed an original OB provider survey to try to understand some of those cognitive behavioral dimensions of experience. Next slide. And so first, I'm just going to present just some brief findings from a paper that we had published earlier this year in American Journal of Public Health, and these were the quantitative ITOPS analysis findings. And so in order to, there's sort of multiple ways to slice the data. We were interested in changes across gestational age, right? Because we hypothesized that passing a law that impacted access to care during a gestational period would change the demographic of who was getting an abortion when, right? And so we looked at less than 20 weeks, 20 to 21 weeks, and greater than 20 weeks gestational age. So those were our categories. Time, we were interested in trends across time. And so we conceptualized the pre-policy period as the period between 2007 and 2012. Then partial implementation, which is what we were really trying to capture, the injunction period, 2013 to 2015, and then full implementation. So what happened when the law actually passed. And so this was a pretty descriptive paper. We examined changes in abortion rates by policy period and by gestational age among the full sample, and also by residents. So again, looking at Georgia residents and also those who were coming out of state to Georgia. Okay, I think next slide. And so here is just a graphic depiction of the trends. And you can see the solid lines are those abortions that were performed greater than 21 weeks. So theoretically, the ones that the ban would have limited. And then the dotted lines are those that were performed during 20 to 21 weeks. And black is the black bar is the full sample, and then the blue bars are Georgia residents, and the orange bars are Georgia non-residents. And so you can see pretty dramatic decreases in abortions performed at both gestational age categories, but especially at the higher gestational age above 21 weeks, particularly in the partial implementation and then in the full implementation period. And so I think that the trends are quite striking and not unexpected, but when you're talking to policymakers who want actual evidence to show, or the community partners and advocacy groups who need the evidence to show actually your policy did have dire impacts on abortion access in the region, well, here you go. And so next slide. And here is a very similar graph, except that we're looking at differences across racial ethnic groups. This paper is under review, actually, but we were looking at Black versus white versus other racial ethnic groups. And so you can see the Black women are depicted in blue, I'm sorry, that's confusing. And the blue lines are the women who identify as Black, or the patients who identified as Black. The black lines are the patients who identified as white, and then orange is sort of the other category. And so the take-home message from this slide is that we saw trends decreasing across all racial ethnic groups with stronger or sort of more steep declines among the Black women or the Black patients. Next slide. And we can just go through these two slides, Lizzie. These are basically just the quantitative tables that show the exact same thing. And sort of these trends were statistically significant across time period, across residents and non-resident comparisons, and across racial ethnic comparisons. Next slide. And so I just wanted to conclude by presenting some of the qualitative work. And so this paper is also in preparation, but my colleague presented for us at the recent APHA conference. And this is represents the qualitative findings from our interviews with abortion clinic stakeholders. So the right thing to do would be to provide care, and we can't. That's okay, you can leave it. And so we explored healthcare providers' perspectives and experiences with the ban. We conducted 20 interviews with stakeholders at 4 different high volume clinics. So these were the clinics that predominantly performed all later term abortions in Georgia. And the interviews were conducted between May 2018 and September 2019. We used a rigorous qualitative coding procedure. So we coded a 100% agreement among a 4-person qualitative coding team and used iterative thematic analysis with both inductive and deductive approaches. Okay, next slide. So clinics have adjusted, we found that clinics have adjusted in order to comply with the requirements of the 22-week ban with very strict adherence. And so as one person stated, it's the law. And I guess next slide, I think, might, let's see. Okay, actually go back one slide, I'm sorry. I was thinking that had a pop-up quote. I've got some animation happening here. One person stated, it's the law. We do not bend or break it. However, there are barriers to and consequences of compliance with these requirements. And so that's what we're going to talk about today. Okay, now next slide. So participants explained that meeting the requirements of the gestational limit places burden on personnel and on service delivery. And these included things like working quickly to see that patients before or on the cusp of the limit could receive care. Other things like completing reporting requirements mandated by the state, such as the ITOPS form I mentioned, and also turning patients away who had moved past the gestational age limit. Next slide. As one participant stated, it makes my job hard because I have to turn somebody away. The look of despair and hopelessness on their face, it bothers me when they feel like they have no choice or their choice has been taken away from them. Sometimes it bothers me so much that I cry in the room with them, or I try to do as much as I possibly can to help get them where they can get to go. So an important note that we often acknowledge is that it isn't the case that the clinics are just simply turning patients away and there's no additional work that happens beyond the denial of care, which is what some of the dialogue, the public dialogue is about. Rather, we found that clinics are doing more work for those patients that can't be seen and that's not been easily measured in research to date. So making referrals, supporting patients who are distressed or depressed, and managing the emotional care and toll. Next slide. Participants also described how the limit intrudes upon the provider-patient relationship. When patients are close to the limit and clinics have to move quickly, this leaves less time for patient decision-making and for managing comorbidities such as anemia or high blood pressure, and then also sudden changes in pregnancy or the pregnancy outcomes such as fetal anomalies. Next slide. So to illustrate, a participant noted that it limits us and the patients that we need to serve. A lot of our patients have fetal anomalies and extenuating circumstances that go beyond 22 weeks. It's perfectly safe to provide abortions past that date, but it limits our ability to provide adequate and quality health care. Next slide. So participants also described how the restrictions created risks for providers. So notably that the bill is ambiguous when it comes to define what criminal abortion and what would qualify as an exception to that rule. So again, we saw this in our OB survey as well. A lot of confusion about the language in the bill and how to actually implement that in practice. And we actually also saw that clinics were implementing it in different ways because they were interpreting the bill language in different ways. And this really added an extra layer of complication when it came to clinic and providers' decisions to take on cases that may have more risk, even if those patients were under the limit. So some patients would be turned away because of comorbidities or pre-existing conditions, even if under the limit. And some of those would carry to term and give birth with those same comorbidities. Next slide. So another participant said, if providers think that the safest way to do for this person's life would be to terminate the pregnancy so that the mother is safe, it's unfortunate because they're making a decision to save someone's life, but they may have to serve time in jail. It's absurd. It makes me angry. And there's laws coming between a patient and her physician. Okay, next slide. So lastly, participants talked about how the limit creates obstacles for those seeking later abortion care, with the impact felt differently for some patients. So challenges resulting from the ban layer on top of other widely documented barriers and restrictions. So for instance, those coming from out of state and their status, those who had to care for others, including children, those having to make 2 or more visits and arrange lodging and transportation and time off of work, and also finding funding and navigating insurance. Participants talked a great deal about how those seeking later term abortions would incur additional costs, such as the cost of an ultrasound, even if they were turned away for being past the limit, and also the costs of travel. So, which participants noted essentially means differential access to care for those with greater financial resources as compared to those with economic hardship and insecurity. Next slide. So this was highlighted in another participant's quote. More of our patients who are later term are the ones who are coming out of state because they can't be seen by neighboring states. Most of our patients are mothers. And so in addition to trying to get a different state, not just for 1 day or 2, paying for somewhere to stay for the night and then arranging childcare, between all of those steps, that it's just financially a burden. And then all of the logistical planning that takes just for someone to even get there to get to their procedure. Last slide. And so just to summarize these main findings, I'd like to bring it back to the first section. Even in the face of these restrictions, we found that the personnel in the abortion clinics demonstrated a commitment to providing quality care for their patients, and they work hard to overcome the barriers to safe and legal care. One participant noted that while it can take more work to provide later abortion care, it can also be very rewarding. And they take pride in being able to provide that quality care and help a larger range of people. For instance, those who discover the pregnancy later or those with sudden changes in pregnancy. And also they saw their role as really critical in helping combat internal and external stigma that's associated with abortion. And so we're really excited to get the rest of these papers out into the world. And we have scheduled a debrief with our clinic partners to really walk through the qualitative findings and get perspective and sort of some of that context. So again, really engaging our partners across all of the phases of research and now for the purposes of dissemination and translation. And so some of this work, we built relationships with the Center for Reproductive Rights and the ACLU in Georgia and nationally. And some of this work has been used in this summer whenever they were fighting the Georgia's 6-week ban. So we're really hoping to continue to develop those partnerships for translation. I think my last slide is just a big thank you to everyone for joining us today. There's my email address. Again, so happy to be back at Columbia and PopFam. And of course, all of my work and interests are just a perfect fit here. So I'm really excited to extend this work and continue new collaborations in the department and school and beyond. So I think we have some time for questions. I feel the virtual applause. And I think maybe, Lizzie, were you monitoring? I couldn't see the chat, but or maybe there's not any yet, but feel free to.
Yeah, I don't see any questions yet, but as a reminder to everyone, you can send your question through the chat, or if you also just want to click the raise hand feature and ask your question live, that works also.
the last seminar. People are probably out of questions. Well, I could have talked forever about the research projects. I mean, there's so many, and I know students have already been reaching out to me at Columbia to learn more about them. And we're swimming in a gold mine of data, and so there's a lot of opportunities for students to think about using the data in a variety of ways. So that's really fun.
I have a question. Wonderful presentation. I really appreciated your storytelling of the center and how you built it. My question is more technical to your statistical analysis for the quant, and I'm going to download the paper as well. But can you talk a little bit more about how you're able to sort of isolate the policy level impact on the outcomes? Because there's a gazillion other things that could be happening at a certain time, and obviously that can
That's
make
right.
Yeah,
that's right. And so, Lizzie, I don't know if we probably don't need to share the slide again, but if you go back, and I think Lizzie can probably post my slides, but in an ideal world, so a lot of the work I do is policy evaluation using quasi-experimental and difference models, which are econometric methods that are much better at estimating causality than simple descriptive work. And so a limitation of this work was that we were limited by the data that we had. And so you're exactly right. There's a lot of confounders that can happen in sort of an natural environmental experiment, like a law often is considered, right? It's a sort of a natural experiment. You can't randomize states. And we know that randomized controlled trials are the best way to look at causality. And so we use multiple regression, and we control for the variables, the very limited set of potential confounding variables at the individual level that ITOPS provided. So ITOPS is like essentially this one-page reporting tool that all the clinicians use to report to the Department of Health. And so you're exactly right. And that's why a major discussion point in our conclusion of our article is this isn't causal, and we're not claiming it is, but it's really looking at descriptive trends over time. We did think a lot about how to isolate the policy periods in the way that we did, and also part of that entailed getting very familiar with the data to really understand what was happening in the data. And so we spent a lot of time trying to understand the cutoff points that were measured in the reporting in the ITOPS form around what happens if you cut off and say somebody is 20 weeks when they're 20.9 weeks, right? Or 20.6 weeks. And so there was a lot of consideration around that. But yeah, in an ideal world, and a lot of my current NIH grants that are under review are using more rigorous methods to try to estimate causal inference. I'm happy to chat more about that anytime. It's really fun.
Great job, Kelly. This is Terry. We have research trying to figure out the impacts of the Title X gag, right? It seems, and then as you know, Golene just did a paper on the Muslim ban. So we have lots and lots of examples of policies that are definitely hurting. So this issue of measurement, I think, is super interesting. It's complicated, particularly with Title X, with the time lag.
Right.
But I think, one that we absolutely have to tackle.
Yeah.
So it's not so much of a question as a comment.
No, I couldn't agree more. And I thank you for bringing that up. It's in several of my grants that I have under review, fingers crossed that they get funded. We have thought a lot about policy measurement. And so we're working with the Temple Public Health Law Program, who are essentially legal researchers looking at how to more rigorously collect legal data and sort of more nuanced legal data in terms of using in a quantitative fashion. And so that's been really fun. It's called Law Atlas is their resource. And they have a fairly focused set of legal databases that they've, in terms of foci, but they are starting to do a little more work in reproductive health. And so that's a focus of two of my other grants. But I think, like Terry, and I think a lot of the projects in the department, as well as many of these with RISE, really recognize the importance of mixed methods approaches. Like, I'm an epidemiologist, I love quantitative methods, but I really also see the limitations of what we can say and how certainly, like, engaging our community partners, they want to also hear the lived stories and the real experiences of how these policies are impacting our communities and our patients and our people. And so I think that we've really heard that loud and clear from RISE's Community Stakeholder Advisory Board about the importance of even community-led qualitative work. And so that's the Sister Love Project. In fact, that's what that was about, medication abortion access. But to me, the nuanced findings that I just presented really give a really important context and lens to the quantitative data, right? And so I felt like that's important to sort of share that together.
Really interesting. I think, you know, as a lawyer coming into this field, it struck me that there was so much research around the world that was leaving out law, you know, looking at access. So I think it's really important to bring all these different lenses here.
Yeah, me too. And as I'm pretty new to policy and to legal research. And so I've been learning a lot. I mean, as someone who's always thought about health disparities and the social determinants of health and things like economic well-being and education and religion and culture and discrimination, the policy piece, I mean, I just really, that was the whole mantra behind RISE. That was the whole impetus for RISE, was if we want to make community change and social change and matter and have things actually matter, then the policy piece is absolutely critical. But I don't look to you, lawyer by training, or the department with the Global Health Justice and Governance Program. But I think it's been a real contribution to Emory and that group. So
To the world.
Well, everyone can feel free to email me anytime. I wish that I could be seeing you in person to say hello, and but hopefully soon. And I really look forward to getting to know everyone and engaging everybody in this work. So and building new collaborations. So I'm really grateful to be able to share today. Thank you for coming.
Really great. Thank you, Kelli. And students, please feel free to reach out to Kelli if you're feeling shy now.
Or tired.
Or tired, yeah. Okay, thanks, Kelli.
Okay, thanks everybody.
Bye.